my screen. I hope. I would also ask, we have got quite a packed agenda, and here it is. If you could hang fire with your questions until the end, that would be really helpful. If you could put your questions in the chat function, because we've got quite a lot of people on here. Rebecca, is it possible for you to admit people? Because I'm showing my screen on here, it's difficult for me to admit people. So if it's possible, that would be helpful. So I'll hand over to John without further ado. But yeah, if you do have any questions throughout proceedings, if you put them in the chat, a lot of the speakers will try and answer them on the fly via the chat. But if they're not answered, I'll try and pick them up and we'll get through them at the Q&A if possible. There's a couple of social media handles on there. If you there they are, HCV Partnership and YHK Record, if you're inclined to tweet. And I will be sending a short feedback form after the proceedings. This presentation will also be recorded, and a PowerPoint, a PDF of the PowerPoint will be available via the Humber Coast and Vale Partnership website, which I'll send you a link to after as well. So without further ado, John, Dr. John Burton, could I introduce you and tell us about the vision for the region to connect care?
So good afternoon, Louise. Good afternoon, everyone. Louise, very formal of you to call me Dr. John Byrne. The only person I know who calls me doctor is my mother. Others just use the phrase John. So look, I'm delighted to be on the call this afternoon. I've brought with me some of my key colleagues, including Lee and Julia, and hopefully we're just going to give you a quick overview of what the Yorkshire and Humber Care Record is all about. We will endeavour not to do too much techie stuff, and we'll try and keep it light. But if you do have deep technical knowledge and you want further details, my colleagues have big brains full of that sort of stuff. So I'll just move on to the next slide. I haven't said who I am, by the way. So look, I am the medical director at Humber Teaching NHS Foundation Trust, which is a community and mental health trust, which we're based in Hull, but we operate out of East Riding, Hull, North East Lincolnshire, bits and bobs. We do mental health, we do community services in North Yorkshire, and we also run GP practices. So I suspect in most of your worlds, I understand most of what you do and how this might work. So look, this is just a quick overview of what the Humber Coast and Vale region is like in terms of the number of people, the number of organisations working in it, and the amount of crisscrossing going on. And you probably don't need me to say it's all a little bit complex, but it's all a little bit complex. So that's the scale that we as the Yorkshire and Humber Care Record are working with just in Humber Coast and Vale. We're also doing the same thing in South West Yorkshire and also the same thing over in West Yorkshire and Harrogate. So we're trying to bring together huge numbers of organisations to connect up data, so to hopefully make your lives easier. But absolutely the key aim here is to improve the quality of care that we can offer to our patients and engage them in that care too. So next slide, please, Louise. So healthcare challenges in our region. This won't surprise you. None of this information here. So on the left-hand side of the slide, you'll just see some stuff about the life expectancy, the prevalence rates for some of the diseases which lead to lower life expectancy in many parts of our patch compared to more affluent areas around the country. It is the way it is. I have to say some of this we think the Yorkshire and Humber Care Record can help with, particularly when it comes to joining up care and empowering patients to look after their own care. But the reality is we've collectively a big hill to climb to cut down some of these gaps. But on the bright side, it's worth just saying about the resources that are available to us in our region. And if you look at the number of healthcare resources, local government services resources, and 12 universities in and out of the systems, there's an awful lot of people that we can call on to think about how we're going to do some of this stuff differently. So I'm not without optimism. So we'll just move on, please. So what is the Yorkshire and Humber Care Record, and what is it all about? Well, there are three parts to our programme, and we can make this as simple or as complex as people want. But the first part of our programme is to bring together the health and social care records for every individual in our region who is touching health and social care, whether it's acute hospitals, whether it's GP surgeries, whether it's organisations like my own who are mental health trusts. And the real win around this is the social care provision, which is provided by many of our colleagues in local government. And if we bring the data from health and social care together, we support people with planning their own care, and it's clear to everyone who's doing what. We think there'll be a better experience of care for patients, and it'll also be more efficient. Key thing about bringing all the data together and connecting all the organizations is it gives you a huge data set. And that data set will be really helpful for us to plan services, not just at a wider ICS level, but more importantly down to place level, if not locality and particularly primary care network level. So each primary care network, which involves health and social care, will understand with a touch of some buttons just what the issues they are facing and how best to plan their services. And finally, this is the nirvana for us. It's the key win. But then how do we go about making sure that patients have full access to their own records and can understand what's going on, and likewise inform the planning which is central to them and their needs? And we're all mindful that there are summary care records, and there's some early work that's been done across the country on that, but we're much more ambitious in terms of how we think this can look over the next few records. So if you think about something like the NHS app, how can we take that further so that you and I can own our own data, control our own healthcare data, and actually just be more informed about our own healthcare decisions? So I'll just move on to the next slide, Louise. So here's just a broad statement. I won't read it out to you because it's just probably just quicker for you to read. But the key thing I'll just focus on here is that this is a fantastic opportunity for us collectively to do something which is slightly different and be ahead of the game nationally. So I'll just move on to the next slide. So I just want to talk a little bit about where we are now in terms of the Yorkshire and Humber care records. Now, I really want to focus up on a huge piece of work we have done around joined up Yorkshire and Humber, which is actually where we went out to citizens and patients in a sophisticated engagement session in sessions over the past 2 years, because we're really clear that we want to work in partnership with patients and citizens, that this is all about them, this is all about their data, and that they understand what's going on and can influence us. And that's been really important to us as we try to move away from the idea that the centre knows best and will do everything for you on behalf of you. So this is just some of the things, the momentum that we've created with integrating the care systems and getting care systems talking to each other from a digital sharing point of view. And we've supported some large scale change projects. I just want to pick out the key point about information governance and security is key to all of this. On our own website, we have a sophisticated amount of information on this, because this is fundamental. If we are going to bring citizens and patients, and that includes you and me, by the way, with us, we all need to understand that the data is absolutely secure and that we control it and that we own it. And that's a fundamental part of our philosophy over the past couple of years, and it'll be the same going forward. So I'll just move on to the next slide. So everyone in the NHS and social care and local government has to have a plan. So this is our 3-year plan. It's interesting, COVID has got in the way just a little bit over the last year, but the team have been sort of cracking on with some of the work anyway. But look, we are pretty confident that this plan, which we have over the next couple of years, will be delivered. And over the last 18 months, we have been tracked by NHS England in terms of our delivery against targets. And I'm pleased to say that actually we have met every single target and every single deadline today. So I'm pretty confident that the people who are on this call and working with you and working in the teams are absolutely going to deliver this, because A, it's mandated that we do it, but actually we're in these roles because actually we enjoy the programme. It's important, and we think it can make a difference to reducing that life expectancy gap for people who live around us, but more importantly, improve the quality and experience of patient care which people receive, but also for many of you on the call that you deliver from day to day. So I think that is my slides as a wrap, Louise, from memory. It is. So now we're going to move on to something practical, and I shall step aside. I hope that was useful for you, and I'll pop back in to pick up some of the questions later on.
Fantastic. Thanks, John. I know you might have to dash off to gold vaccine stuff. So thank you so much for your time. Really great to hear about the progress and your independence, as it were. So yeah, check in with you later. So yeah, we've got Avi joining us now, who's GP and IT lead at the CCG, which is fantastic. Avi, thanks for joining us. So we haven't got any slides for you, but you're just going to talk about sort of, you know, the Yorkshire and Humber care record in practice. Is that right?
Absolutely. Thank you, Louise, and thank you, John. So just a little bit of a background as to who I am. I'm a GP at Riverside Surgery in North Lincolnshire, and we send our patients for care at the local hospitals, being Scunthorpe and Grimsby. I am also the GP lead at North Lincolnshire CCG group, and I've been involved in this very exciting project now for the past 18 months. And I'm just going to give you some sort of practical advantages as to why I strongly believe that this Yorkshire and Humber care record is beneficial to patients and our health population in general. The first sort of immediate win that we see is the fact that our administrators within general practice got access to information a whole lot more easier. Now, in the past, when a patient was looked after by another health provider outside general practice, we were reliant on information about that patient's care coming in via phone conversations with the health provider, either social services or an urgent fax coming through, although we don't use fax machines anymore, from secondary care. And the problem, the challenge with that is there is always a delay between these vital bits of information reaching us, the GPs, in order then to provide smooth, efficient care for our patients. And the beauty of the Yorkshire and Humber care record is the fact that it provides you a single portal where all this information is pulled together and access to that information is instant. So one of the first few things that I had to do in my practice is to win over my secretaries to say, look, I'm going to take you on a journey, but it's going to make your lives a lot easier. And in the end, it's going to improve the overall health provision for our patient population. And very soon, what our secretaries found was rather than having to chase up a hospital department for the results of a patient's care, they could actually just get on the portal and download that information at the press of a button. Now, that really streamlined patient care on a day-to-day basis. So when we won over the support of our secretaries, the next step was to win over the support of our doctors within the practice. And I like to go back to an example, a real-life example that I had myself at the very beginning of lockdown, when we first started doing video consultations. And I remember I was reviewing a child who had developed a rash, and I was doing a video consultation, and I was quite chuffed at the fact that I could do this all remotely. And, you know, I said to the mum, well, if things get any worse, then over the weekend, please get in touch with the out of hours doctors. And mum was happy with the care provided by me remotely at that point in time. And sure enough, by the time I returned to work the following week on a Monday, I was told that the child had deteriorated over the weekend, and the child was now being looked after by a tertiary care setting in Leeds. Now, as a clinician, you can just imagine that the first thing that came to my mind is, what did I miss? You know, was I providing good care? What's going on with this child? Have I let the parents down? And as a clinician, I think a lot of people underplay how much that affects you in terms of the rest of the day, doing the work in-house. And then I took a step back and I said to myself, well, usually what would happen is I would have to wait a week after the child was being discharged from Leeds before I got any news about the child. But at that point in time, I realized that actually we were signed up to the Yorkshire and Humber care record. And once again, at a press of a button, I was live into the Leeds care record where this child was being looked after. And I could actually see in real time what investigations were done for the child, how well the child was doing, what the follow-up plans were for the child. And that really put my mind as a clinician at ease. And it allowed me to continue on with my day knowing that, well, actually, you know, the child's in safe hands and I didn't really miss out on much. It was just a very atypical presentation. So I can't stress the importance of being able to have that data immediately to my hand because it allowed me to go on with my day. And more importantly, as John was trying to say, this is all about empowering patients and putting patient care at the very front of what we deliver. at whatever health providing settings we work from. And this brings me to the final point of my presentation today, which is how did I get the patients within the practice to sign up to the Yorkshire and Humber Care Record? We had a patient who was part of our patient participation group, and this was a patient with a very rare form of cancer. And because she had a very rare form of cancer, she had her care being provided at many different care settings. She was looked after by the oncology team locally at Scunthorpe Hospital, but she was also under the expert care of the oncologist at Leeds. Now, what used to happen is this patient would have her follow-up at Leeds, and she would see her oncologist. Her oncologist would say, right, I'm going to change some of your medication. Your GP will hear back from us within a week. But sure enough, because the patient was anxious, the patient would be back in my room a day after the follow-up with the oncologist saying, look, Dr. Pillay, is there any chance that, you could get in touch with Leeds and find out exactly what's going on? And, let's try and get a little bit of movement on my treatment. And for quite a while, it was very difficult to get that in place because once again, it was me getting in touch with the secretaries saying, can you please chase the oncology department? Let's see what the latest information is. Or the secretaries waiting for correspondence to come through, which would be delayed by a week or, sometimes a bit longer. And once again, now with the advent of the Yorkshire and Humber Care Record, we could see the information live. So it was great to see that the management plan done by her specialist in Leeds from the day before was available for a live review when that patient was in my office the day after. And patients will not always ask their specialists all the questions that they have to mind because sometimes the information given at that care setting is a bit overwhelming. So by the time they reach home, by the time they've had a chance to think about it, the list of questions then evolve, it changes. They see their GPs who they've known for many years, sometimes a lot more better than the specialist that they're meeting for the first or second time. And they come to you with a list of questions, which at the best of times you can't answer because the information that you have at that point in time is not up to date. But once again, via the Yorkshire and Humber Care Record, I could quite easily just get on the portal and get that information live. So now I've basically suggested 3 different anecdotal scenarios in which it's revolutionized the way that my administrators work within general practice. It's helped me become a more proficient overall clinician in my day-to-day practice, but it's also allowed the patients to have better care. So I'm just going to share what happened next within my practice. This patient was so thrilled that she could see her information live that being part of the patient participation group, she said, look, Dr. Pillay, what we really need to do is we need to get this out to all the other practices in North Lincolnshire. And I said, well, if you don't mind being the voice of reason, the best delivery tool here is the patient themselves. So she sat in front of our 19 GP practices at a local quality improvement program that we had. And she basically said why she felt that this program was actually something worthwhile investing in. And sure enough, it didn't take much of a sell because all 19 GP practices in North Lincolnshire signed up to the Yorkshire and Humber Care Record. And just to make it clear, this is well before the Yorkshire and Humber Care Record started actually linking up with the local hospitals. And that's one of the biggest challenges to try and get across to clinicians. You may not see the immediate use of the Yorkshire and Humber Care Record just yet, but with the different waves and the different roadmaps, you will start to see that it's one of the most useful tools that will automatically be incorporated in your day-to-day practice. So I'm going to keep my presentation short and sweet. I believe Julia is next, and Julia is going to talk you through the roadmap moving forward. And she's going to put a little bit more flesh with regards to what I've just explained to you. And I'll leave it to that, Louise.
That's great. Thank you so much, Avi, for sharing, your personal story there. And yeah, I think it's incredible that this tool is really it's so valuable to primary care, but also to secondary care and other areas of care. Just having that joined up view. So thanks so much for sharing that. I think it just puts it all in context, really. So Julia, are you here? Can you put your camera on and your mic on? Let me just move on to your slide. Are you here, Julia?
Yes, I'm here. Can you hear me?
I can hear you now. Yeah, I can hear you now.
Great. I will just turn my camera off though, because I'm not sure my broadband can cope with too many videos. So I will put my camera on. But hello everybody, and Thank you for giving me the opportunity to speak to you this afternoon. My name is Julia Millman and I'm the Integrated Care Programme Manager, which means I have the job of working with a wonderful team of experts in order to develop and support adoption of the Yorkshire and Humber Care Record across the region, which we hope will continue to support the transformation of integrated care, as you've heard John and Avi describe so far. I'm just going to touch upon the frustrations, almost the as is and the to be picture, if you like, and give you a little bit more visual around the concepts which Avi just described to you. And then we can touch upon where we go next and things like that. So here on this first picture, I'm sure this slide will ring bells for many of you on the call. Of course, health and social care workforce people are frustrated. They often have dark spots in terms of the information that they need in order to support a patient well, as you can see on this slide. In fact, only this week, a friend of mine told me how he's waved off his mother in an ambulance which was taking her to a care home. And the lasting image that he has is with her laid down with a heavy paper file dropped on her chest. So that's not right, is it? It's hard to reconcile this situation really to the rest of our lives, where we can push information around at the touch of a button on our smartphones, can't we, all the time? The reasons really that the health and social care systems suffer in this area is partly due to where we came from. So the NHS is a place where organisations used to operate independently, providing reactive care. Also, where digital standards are very immature, and it's a place where data is very sensitive and personal, and where thought and consideration about sharing needs to remain with citizens and people. It's also a place where organisations have to balance the adoption of digital services with some very pressing and competing priorities, as I'm sure you appreciate. And we hope this is where the Yorkshire and Humber Care Record can help. So let's see if I can bring it to life for you a little bit. Can you move on to the next slide, please? So let's think again about the Yorkshire and Humber region, which John described to you earlier. So you can see the statistics on this slide again here in the little boxes. There are 5.5 million citizens across the region, and our workforce is around 200,000 people. As Avi's just described to you with his patient, people move across the NHS all the time. So here we've got the little person in the middle. This person, this could be a patient quite easily and could very easily have had an operation in a district hospital and then, as Avi described, move across to a tertiary centre and then have to relay that story back to his own GP. They could have had many trips in an ambulance, and the ambulance have got information that they might need to share to the urgent care department. And the person might also be supported by community services or social workers who would find great benefit in understanding the journey they've been on if they have had a stay in hospital, for example. So this is the white lines on this picture here is really where the YHCR technical solution helps. The YHCR information exchange, which you can see with the circle around the black patient, it enables organisations to share and view information safely and securely using their own systems without the need to log on to a separate system, which of course is not a good idea. So the sharing is done on demand. So on demand means that if Avi wants a piece of information, as he described earlier, he wants information from the hospital, he presses the button and he gets that specific information, not just a big old encyclopedia with lots of information. And the YHCR does all of this in the background at a system level without the care provider needing to think about it. The aim is then to allow people to see one virtual patient record in a way across many different organisations. And obviously, the safety and security of that information is very, very important. And it's at the forefront of our developments all the time. So let's see why all this matters then. Can you move on to the next slide, please? Our citizen research shows that we have strong support for this type of initiative. And this has become even more apparent with the onset of COVID, as we know. The trust in the NHS is high. 95% of patients in our research supported that data should be used for direct care and even beyond direct care into research. So let's see if we can tie the plans which John described to you earlier into some more tangible benefits. So John talked about the sharing of care plans. So strategically, that's all about improving patient experience, which is obviously an ambition for all NHS organisations. Let's talk about end of life plans specifically. I do know of a patient in our region who was in the end of life phase of their life and actually had to describe their end of life wishes in 7 different consultations with 7 different care providers. The YHCR is able to push around a virtual care plan, which care providers can annotate so they can almost pass the baton and pick up where the last care provider left off. So if your wishes have changed because your condition has moved on or your family circumstances have moved on, you wouldn't have to start from the beginning of your story again. You would be able to annotate that, and of course you'd be involved in that consultation as well. A very important thing to mention there is that the Yorkshire and Humber Care Record is relevant to health and social care colleagues, and so many of those end of life wishes might be relating to your social care service and your social care considerations, and that's absolutely fine. We can actually take care of that as well. So John also talked about our ambition to increase connections between primary and secondary care. And here, if you look on the picture, this is picked up in access to better information faster. So strategically, this is all around efficiencies. You know, historically, the NHS has been heavily reliant on faxes and telephone calls all over the place, which, if you think about it, costs a lot of money. Just drilling down to one of our more mature cities, which is Leeds, where we have a relatively mature care record in the city called the Leeds Care Record. They are already demonstrating up to £7.8 million of efficiency savings only by eliminating the need for GPs, for hospitals to call GPs when they need to understand medical records. And that's, as I'm sure you'll agree, quite significant. So just to build on Avi's story, which was a wonderful story about how a GP's experience was much richer with a patient because of his ability to see hospital information, I can also tell you a story about the other way around. So another one of my colleagues works as a cancer consultant in a tertiary centre, so the other side of the coin from Avi here. He was able to continue a patient conversation with a patient who he'd never met before, right at the point where the GP had completed that conversation and requested the consultation in a tertiary centre. So in effect, the patient had a terminal diagnosis, and the nervousness for the consultant was to understand whether the patient and his family actually recognised the terminal nature of his diagnosis. When he looked at the GP information, he was able to highlight that the GP had already had a very rich conversation with the family about this. And so rather than going in cold and looking a little bit like it was a rather uncaring consultation, he was able to pick up and discuss what had been already mentioned and take the conversation forward from there, which again gives you a much, much richer patient experience. So up to the top left of the screen here then for a moment, looking at information for urgent care. We've been working really hard actually over the pandemic to work with the Yorkshire Ambulance Service and our urgent care settings in order to enable a digital transfer of care. Now, strategically, again, this is all around reducing the time that it takes to transfer a patient from the ambulance into hospital, because that's the longer the time, the higher the cost. The sort of numbers that we're talking about really there are about £1.8 million in an annual period. So we have highlighted a digital and delivered actually a digital transfer of care, which means that patients in Leeds, for example, and Rotherham now, when they're dropped off in the ambulance, the administration on their transfer into hospital is roughly speaking 5 minutes shorter per patient. Now in Leeds, they do deal with around 200 transfers a day, 200 patients coming into Leeds a day from an ambulance. And if you associate that 5 minutes with the 200 patients per day and work it out per month, that's around 500 hours. Now, in our new world of COVID, we've highlighted a new benefit there, which is obviously the benefit of reducing pressure on the administrative services, because in COVID, many of the admin teams were unable to attend work because they were isolating, for example. But instead of this causing a major issue, we were able to manage that situation and move things along quite nicely. So I just wanted to close really from a benefits point of view by thinking about the most important people, and that's obviously patients themselves. We are always led by patients and citizens, and we want people to understand and remain at the centre of their care at all times and understand what we're doing. With the Yorkshire and Humber Care Record, we do have the ability for patients to access and contribute to their own record, and this is vital, I'm sure you'll agree, because the biggest part and the person who has the most knowledge about a person's health is, of course, themselves. So that's really where we are from a kind of shaping the future and the benefits and things. In terms of our roadmap, it's fantastic at this point, because I do feel personally that we've walked up a very big hill. We've been working really hard to work with our partner organisations to get early adoption and early data provision so that we can start adoption at scale. During the next year, we're now hoping to push that adoption really fast, connecting around 74 organisations by September 2021, and working really hard on looking at the usability of our new Yorkshire and Humber Care Record portal and how that can support third sector and other NHS organisations. So we really are at the point of a lot of excitement in the team at the moment, but I think I've probably just reached the time that I was allotted. So maybe we'll pause there and hand over to yourselves to talk about any questions.
Thank you very much, Julia. That was great and really insightful. I think what I'm going to do, there is a question on the chat, and please feel free to add your other questions on the chat, everybody. What I think I might do is I might move back to one of John's slides, this slide here, which I think is quite useful. It's just a sort of useful reminder to everybody about, who's already connected within the region and some of the work that's going on. So we've got a really interesting question from Paul at Tiny Medical Apps about their engagement with the care record as they go live with their PHR at Sheffield Children's Hospital around asthma and allergies, and it focuses on sharing their care plans. But Paul's asking, I don't know whether anybody on the team here is able to know what the sort of timeline is on the patient captured data, i.e. the symptoms being put back into the medical record or back into the care record. I don't know if anybody can take that question.
Yeah, I'll assume, Julia, I'll take this one if that's okay.
Thanks, Lee. Nice to hear from you.
Yeah, Lee, that's fine. Thank you.
Okay. So we are just starting off with Sheffield Children's. We just started to do that piece of work as them as an organisation, and the timescales are likely to be 3-4 months to actually get them, as long as everything goes well, to get them connected. Now, for Tiny Medical Apps, we'll need to connect the application to the Yorkshire Humber Care Record. So I suggest, Paul, we pick that conversation up. We have done that with Helm We have done that with Black Pear and other applications where there's a process to connect. Probably if we can tie in with you, Kevin, and for Sheffield, then we can put a bit more of a coherent plan around that on the timescales. So you are definitely on the list. And I remember when the bid went in, it was an expectation you would connect to the Yorkshire Number Care record. So we've just got to fulfil that. But yeah, it generally takes 3 to 4 months to connect, depending on technicalities and how we map data. And it will communicate both ways now. It's just whether the systems and the technologies are ready to do some of that type of stuff. Just because sometimes we do find issues with data mapping. So, you know, are we calling an apple, or is it actually an apple with a bit of banana stuck in? And that makes a big difference, especially on some sensitive data. So yeah,
fantastic.
So hopefully that answered the question, Paul. I would suggest we just get in contact with outside, and then we can progress that in conjunction with what we're doing with Sheffield Children's.
Brilliant, thanks so much. And Paul has put his thanks on the chat. That's great, thank you.
Yeah.
While you're here, Lee, I think there's another question here. Dave Jackson's asking what engagement so far has been done with any of the social care software providers, people like Liquid Logic, people like that. Is there any linking into social care records so far?
So, Julia, do you want to pick the connections with North Yorkshire up, or do you want me to continue?
You continue, Lee. That's fine.
Okay, that's fine. Thanks, Julia. So we are connecting with North Yorkshire Council who do Liquid Logic. That's in a pretty good place. The only thing that's really holding us up there is to get a user interface, which is a part of another piece of work we're doing. So yeah, we are engaged with North Yorkshire, who use Liquid Logic. We're also heavily engaged with Nottinghamshire, because they're very connected into data mapping and systems. We've yet to expand from the Liquid Logic solution and look at other local government providers. It's really been from a Yorkshire Humber perspective of which local government bodies want to be involved at what phase and how we schedule them in. So the answer is Liquid Logic, yes. We're nearly there with North Yorkshire. Just a user interface. We are looking that if we've done that one particular connection, it should be easy to do all the others. And then we've got the other systems to knock down. So hopefully that answers your question, Dave.
Great, thank you very much.
I think sorry, can I just add to that, Louise? I think it's also important to mention that with respect to the work that we've done with North Yorkshire County Council, we are hoping to standardise the data set that's associated with the sharing from North Yorkshire County Council at a national level, and we are working with other partners and suppliers out there to try and sort of work collaboratively in terms of moving that forward to the next stage over and above our work that we've done within our region.
Right, thank you. And I guess it's one of those things, if you've done it for one system, then you've kind of probably done 50% of the work when it comes to looking at other systems as well, I guess. Well, that's a hope.
Yeah, there is another challenge in social care that there isn't any standards for data. So there's a bigger piece of work on data mapping.
Yeah, that it is much more around the data mapping that's relevant in that. Yes, correct.
Yeah. Which probably leads on to Ian's question on data mapping.
Doesn't it?
So we have been working at an organisational level on data mapping, but once we have mapped once, we can then move that technology, because basically there's an integration path to it, and that can be then lifted and shifted to other organisations. So once we've done one Lorenzo, then the next Lorenzo, or at least the bits of the same Lorenzo can be shared, assuming we're using the same technology on that side. From a mapping point of view, I think we've seen that as an opportunity to improve, and there are some gaps in our approach. So we have been very lucky to receive a bid or be successful in a bid for the Shared Care Record Fund. If you're aware, September 2021, health organisations of primary care and trusts need to be connected in a minimum data set, which we are obviously pushing forward on. Thanks very much there, Louise. So we are putting that as part of the work around data mapping, because really we really need to productionise it. We really need to get it at scale, and then we can share that to other regions as well as our own to others. The issue with data mapping issues are just different people use systems different ways. So especially if you've got an example will be a locally hosted versions of Meditech that's been set up 5 years after the next one. They may be using SNOMED in some ways, but again, there'll be some inconsistencies of the data. So the real issue is actually having them data sets and linking them into FHIR, which is the other issue. So one item we have done is we've done a national piece on mental health data mapping to standard data sets and linking to FHIR. And the benefit of that has been 2 items. One, it's clear that only 50% of that data set matches to FHIR past health interoperability standards. I could be wrong on that statement, but it sounds plausible. Is a standard to use and lift and shift data between systems. Just because we've got data items in SNOMED and another system doesn't mean there's actually a standard to transmit it. And that's where we're going to come up with other standards. Stuart, hopefully that's helpful, Dave. So prioritisation, our priorities based on our ICS colleagues. So we get that through each of the ICS leads. There is a outline plan, which the ICSs can share, and that's where we're looking at priority. Now, I think there's a reality slant. This work definitely takes a bit of time. Connectivity is easy, change is really, really hard. And if we're going to make that difference, we've got to change the way we work. We want jet planes and not faster horses. Unfortunately, we generally think we want faster horses. So there is the next focus is around transformation, more than our historic, let's plug a load of things together and hope somebody goes for them. It'd be good to pick up with Stuart on the mapping that you've done in East Yorkshire or even from a Humber Coast and Vale. We have tied in with Pop Health, so we've met with Optimum and Carina and looked at how the population health tools that we've got from a Yorkshire Humber Care record and how that ties into the next Optimum radar piece of work, Stuart. So the Optimum team are currently building that into their long-term plan to build on when they exit the current initiative. So we are working collaboratively. There's real opportunities there of how we can use the technology we've got for Yorkshire Humber Care record and complement, not replace what's happening. The issue is then start doing it. Next have some really, really good skill sets and good sets of data. We're going to start getting there. It's just using what we've got as effectively as possible. And yeah, we'll catch up, Ian. We do need to pick up that conversation.
That's great. And thanks, Lee. I've got a quick question, if that's okay. I know you've sort of talked about some of this work that you're doing, in terms of mapping data, working to integrate systems. Some of this you can sort of feed in nationally. Does that mean that this will allow, organisations like NHSX or Digital or whoever to share this with other regions that are looking at care records?
So I'm going to be a little bit cheeky at this point, Louise, because I think I saw some people on the call that may be able to answer that question for me.
Oh, do it if you can.
Yeah. Is John Farrington still on the call? Yes, he is. John,
lovely to
not put you on the spot, matey, but would you like to answer that one?
Thanks, Lee. I'll remember that.
I'm doing it from a positive way, John. We are quite learning and sharing, aren't we?
Yeah, so for the benefit of those I've not met before, I work in NHSX. I'm the senior programme lead for the Shared Care Record Programme, formerly known as LICRA. And the point we're trying to do is that while we can nationally set some standards, we also want people to try stuff out locally and inform what it is that we want standards for. So it's a kind of bilateral thing. And one of the jobs we have to do is to facilitate conversations between different people working on these sort of projects around the country. As Lee will know only too well, we have a thing called the Architecture Editorial Group, which tends to be the technical architects that meet every couple of weeks, have a conference call and swap notes. So we've got peer-to-peer working there, and from a national point of view, we listen to what people are saying and try and say, there's something we ought to take responsibility for nationally, do once, and then there are other things where we really need people to let let rip and work out the local solutions based on the systems that they've got in their place. So it's a bit of a mixture, really. COVID has sort of got in the way of our regular national conferences, although we are planning one. I'll do a little advert now for third week in April, which is after Easter. We'll do a virtual 2-day conference to allow different organisations that we've been working with across the country to share and show and tell what they've been doing. So we'll make that very open, and it's an opportunity to see the different approaches that have been taken in different parts of the country. But ultimately, it's back to what John said right at the beginning. This is about making sure that healthcare professionals have the access to the information they need to give the best possible care to patients that are in front of them. And whether that information is captured from local systems or from distant systems, who knows? But we have seen some really important things happening, and particularly in COVID, where some of the patients, for example, in London have been transferred to other hospitals in other parts of the country. If only we had a network of local health and care record systems operational, then the professionals seeing them in those new locations would have the same access as those in their kind of home locations. So we're working in that direction, and we're trying to facilitate the conversations, not just around the technology, but also the learning about the transformation, about the information governance, how people are funding this, all those other things that are associated with a successful deployment. I'll switch back to Lee.
Thank you, John. That's great. Before you go, John, this event that's been planned in April, has it got a name, or where would we find out more information about that?
We're just trying to nail it down in terms of time and location. When I say location, it'll be a virtual location, and we'll push the details out through our networks and let them cascade to their people as well. And we'll tweet about it, and you won't miss it.
All right, that's great. Lovely to hear from you, John. Thank you. We've had another question in from Gemma Oliver. Do we have an idea of when Wave 3 organisations will start to be engaged on getting on board? Lee, is this one for you?
Yeah, I can pick it up. So Wave 3, I mean, the waves are a bit immaterial now, really, because we've got Wave 1s that have finished before Wave 2s, and we've got some Wave 2s that have stepped back. So the next tranche of organisations, we are going to start very shortly. There's a requirement to expand the ICS team and ourselves, which the additional funding from our own ICSs and also the Shared Care Record Fund will help. The exception being TPP. So it's worth explaining with TPP, we're working with them with the view to have one connection. So when we do get it all working with TPP, there'll be a whole swath of organisations that get connected to the Yorkshire Number Care Record that work once, albeit we've still got to have information sharing in place, and we still need to work with consent, informed consent, privacy notice, transparency are absolutely required. But that means there's a whole batch of people who can move really, really rapidly on that next wave. So TPP, I'd say, is a real opportunity. We just need to knock a few items down. We have a really, really good working relationship with it. We have been testing things in our sandpit environment, with their sandpit environment, to see if they actually work. So that's where we are. So we are starting on the Wave 3s or the next waves now. So some of the team will start getting in contact as we expand to do that. What we don't want to do is start a conversation and then we slow down just because we don't have the resources to move things forward. Okay. So Gemma, just as a question, which organisation are you?
City York Council. So we're one of the councils that are on something that isn't Liquid Logic. We're on Mosaic.
Okay, Mosaic. Yeah, well, okay, that's a pretty well-known system. Although it's lost business to Liquid Logic, but everybody did it at one point. So yeah, I think the problem we got, Gemma, is I think local government was slightly further down the line. But again, it's definitely worth that conversation. If you've got North Yorkshire and yourselves in that northern end of the patch, there's some real benefits because we've got York that are just about there. We've got Humber that are already there, so that'll create a great level of connectivity, especially if we expand to care home access and third sector access. So yeah, Julia will follow up on that with that one, and we probably could do, Julia, to pick that up on the whatever it's called, the North Yorkshire and York Digital Leaders Boardy thing. Debbie's probably going to
Oh
tell
yeah,
you
I know which one you're talking about.
for
Yeah,
hashing
yeah.
hashing that meeting to bits. But I think there's an opportunity to pick that, just to check that sequencing and ordering, if that's okay.
Yeah, Lee, it's probably also mentioning that, you know, all the connectivity that you've just described is very much driven towards data provision, and we're also stimulating a lot of onboarding with respect to consumers. So if you think about that transfer of care conversation I talked about earlier, we're already engaging and halfway through the onboarding process with East Midlands Ambulance Service, for example. And we're also keen to look and work with consumers from the GP Connect perspective, because we've made a lot of progress both with respect to HTML data, which is more of your one picture view, and structured data, which is more where you can meld the information in with other care settings. So that's probably worth just pointing out. And our prototype portal is available, and we also have a new product manager who's going to be rustling up user-led kind of product development soon on that. So it's exciting times.
Fantastic. Thanks, Julia. Thanks, Lee. Well, I think we've kind of come to the end of our questions. Is there any specific ask? I mean, we've got 40 odd delegates still on the call, I think, from a really wide perspective of health and care across the care record. I mean, is there any messages, Julia and Lee, that you want to sort of send out? Anything that anybody else can do to help with this before we go?
I think from me it would be that obviously in the Humber Coast and Vale, to just highlight who the key players are within the Humber Coast and Vale. Is that fair, Lee, do you think? Working who people should contact next and that kind of thing, Louise.
Yeah, so yeah, yeah, you're absolutely right, Julia. So we've got John Mitchell, who it would have been Debbie, but unfortunately Debbie Westmoreland's moving on to bigger and better things. So we have got a slight gap on that side of the system at the moment, and we're looking for another person to pick that up. We have a delivery board which is led by the ICSs with a small part of the system. So Christian would be normally the point of contact, and we've also got Ian Anderson from Hull City Council in this patch. Not forgetting Neil Bartram, who is the local government lead as well for the whole of the Yorkshire and Humber Care Record side of things. But that doesn't mean that, you know, if you're going to contact somebody, you can contact the team to ask questions. We're working with the ICSs from priorities. We also have John Skidmore, who is the ICS executive lead, and there's Martin Slingsby and that part of the team as well that are also good contacts. So they're a good starter for 10. Normally it'll be Debbie and John, but yeah, well, I'm sure John would take the calls for the northern end of the patch. So yeah, I think that's a fair point, Julia. I mean, the other thing I would probably say is what would be really useful, especially for the Humber Coast and Vale colleagues, is how would you like us to communicate to you in the future? So it's more of a question to you to come back to us. We've never really got an absolute super balance. We've always got webinars, emails, we've got websites, and it's just how we can do that effectively and usefully without saying, here's another Yorkshire Humber Care Record report saying how brilliant they are, which obviously we would try and be on a fairly positive but realistic slant. But how does that really work for you or fit into the groups or the initiatives you're working at? Because you're far more aware of what's going on in your local organisations in your place than myself and Julia have ever been. So it'd be really useful to get some feedback from the attendees, how you think we could probably improve that, either by ourselves or in conjunction with our ICS colleagues, just to keep that conversation going, so we don't miss opportunities. Because I don't think we probably mentioned it, Julia, although we may have done, where we've done some additional development for 111 First.
No, we haven't mentioned that.
Any booking, which is really a local requirement for Humber Coast and Vale, which is really which is coming together really well. And I wouldn't be surprised if that doesn't expand. And also being realistic of what we can't do. We can't do everything, or it's going to take time to do it, or it's just not worth investing the money in the Yorkshire Humber Care Record. We invest it somewhere else. So, you know, there is a pragmatist view. So yeah, some feedback on how you think we can improve communication or how you can inform and give us direction would be extremely helpful. Okay.
Fantastic. Thanks, Lee. Sorry, I was just on mute there for a moment while my dog was having a little chelp. Okay, guys, I think I'm going to give you 3 minutes back. Thank you so much, Lee, Julia, Abby, John, for taking part, and John Farrington as well for his cameo. Really great to hear all the feedback. And I'll send. I'm going to send an email out asking feedback from the delegates. But great to see you all, and catch up soon. Stay safe, everybody. Thank you. Bye bye.